More than 130 people in the United States will die of an opioid overdose today. Americans now face greater lifetime odds of dying from an opioid overdose than from a car crash. The global scourge cuts across all communities and affects every corner of society. No family is immune. No single culprit is to blame. We know of no clear and simple fix. We do, however, have good reason to hope, as well as we have great leaders in myriad fields and multiple sectors working to better understand and meet this crisis. This crisis must be met. Today's program is very special because our panelists bring an important mix of insight and expertise to this incredibly complex epidemic. So please join me in welcoming on stage Bertha Madras, Jeb Bush, Jim Kenney, Jean Marie Perrone, and Joe Biden. So there's no better place than Penn for this forum because we have long played a role in this essential effort. One of our panelists recalls that back in 2005, the United States faced a fentanyl outbreak. Philadelphia was one of the major cities affected. When the time urgently came to convene the very first national forum on fentanyl, Bertha's first phone call was to Penn. And as a result, in 2006, a multidisciplinary gathering of clinicians and researchers, students, lawyers, and law enforcement officials all met here to share knowledge and plan action. That Penn gathering was a landmark meeting, and it brought national attention to the rising threat of fentanyl in communities nationwide. So now, in 2019, Penn gathers anew to confront the opioid epidemic. We're so grateful to the special friends of Penn who made this program possible. We honor the memory of Penn's former trustee leader, David Silfen. Together with his wife, Lynn, they generously endowed the David and Lynn Silfen University Forum. Let us all thank them with a big round of applause. We're also grateful to the 5 remarkable expert panelists with us here today. Let's meet them now. Joe Biden served as the 47th Vice President of the United States after 36 years as a U.S. Senator from Delaware. One of the outstanding statesmen of our time, he is the recipient of our nation's highest civilian honor, the Presidential Medal of Freedom with distinction. Vice President Biden is also Penn's own Benjamin Franklin Presidential Practice Professor. He leads the Penn-Biden Center for Diplomacy and Global Engagement in our nation's capital. Vice President Biden and his family, as I think you all know, have long and close affiliations with Penn. Thank you for being with us, Vice President. Former Florida Governor Jeb Bush served 2 terms leading our nation's 3rd most populous state. Governor Bush has been celebrated for his success in reforming education and helping to close the achievement gap between rich and poor. He became a leading voice in the national discussion about immigration reform and political consensus. Governor Bush also has a very special connection right here to us in Philadelphia as formerly serving as chairman of the National Constitution Center. And of course, he has a special connection to the Penn community as our 2nd esteemed presidential practice professor. Thank you so much for being with us, Governor Bush. The Honorable Jim Kenney is the 99th mayor of Philadelphia, a native son of our city and a lifelong public servant devoted to the welfare of Philadelphia's people. Mayor Kenney's administration is committed to expanding access to education, investing in the city's commercial growth, and pursuing greater health, happiness, and prosperity for all Philadelphians. Foremost among these priorities is the city's response to the opioid epidemic, including the Philadelphia Resilience Project, which has mobilized community organizations, residents, and 35 city departments to combat the crisis. At Penn, we are enormously proud that Mayor Kenney was for years a lecturer at our Fels Institute for Government. Mayor Kenney, we love your relationship to Penn, and we're proud of your leadership of our city. Welcome. The Honorable Bertha Madras is professor of psychobiology at Harvard Medical School. She served as Deputy Director for Demand Reduction in the White House Office of National Drug Control Policy, a presidential appointment confirmed by the U.S. Senate with unanimous consent. A prolific researcher and author, Bertha focuses on neurobiology, brain imaging, and medications development. In 2017, she was appointed to the President's Commission on Combating Drug Addiction and the Opioid Crisis, and was asked by the chair to shepherd and write the final commission report. She currently is a member of the National Academy of Medicine Collaborative on the opioid crisis. Thank you so much for being with us. Dr. Jean-Marie Perron is a professor in Penn Medicine's Department of Emergency Medicine, and she directs the Addiction Medicine Initiatives. She has led many investigations into opioid stewardship and has advocated at the state and national level for emergency treatment for opioid use disorder. She has served Philadelphia's Mayor's Task Force. She served on the Pennsylvania State Opioid Task Force, the National Quality Forum, and advisory committees with the CDC and FDA to address opioid overprescribing. She is triple certified in the fields of emergency medicine, medical toxology, and addiction medicine, and she was inducted into the Penn Academy of Master Clinicians in 2015. Thank you so much for being here, Jean-Marie. So as you can see, we have an exceptional group of panelists to share their insights with us, so let's get started. Mr. Vice President.
Start with the least informed.
No, you wrote, and I think I quote you, that America's opioid crisis is tearing the heart out of this country. In your opinion, how did we get to this place? What's happened?
Well, we have some real experts on this panel, but I have, look, more people die on a yearly basis from this opioid crisis than died in the entire war in Vietnam. To put it in perspective, this is not a minor thing. And I think we can't look at this crisis, but I yield to the two docs on the panel, without looking at the abandon with which the drug companies advertise painkillers, without the requisite, in my view, the requisite warnings of what it's about. And quite frankly, docs who I believe willy-nilly overly prescribe. I wrote this statistic down. 282 million prescriptions were written at the peak in 2012. 215 million prescriptions for painkillers in 2016. That's enough prescriptions written to keep the entire American population medicated around the clock for 3 weeks. Now look, we desperately need people with chronic pain to have this access, but you cannot convince me anywhere near that is the case. And the millions and millions of dollars hundreds of millions of dollars, these drug companies spent on advertising is just, and deductible. as a business expense. I'd take away the deduction if I could. You know, the fact is that, as the docs can tell you, and the mayor and the governor, that a lot of people can get addicted within 5 days of the use of Percocet and these painkillers. 5 days. 5 days. And I think, Doc, it may not be the case, but I remember reading something where you said that close to 80% of the people who have a wisdom tooth out are given 7 to 10 days worth of painkillers.
So that's, go ahead.
And so I think you have to look at two things. One, we got here, I believe in part, because of the greed of the drug companies and their responsibility of them. And quite frankly, the lack of sufficient responsibility on the part of the medical profession. And so I think there's a lot of things I think we can do to change it. I'm not going to talk anymore, but there's a lot of things we can do to impact on that without in any way violating any of the elements of the medical profession and without punishing drug companies unnecessarily. But you can't convince me that, look, there's one town in West Virginia, I wrote this down too, one town in West Virginia, between 2006 and 2016, drug companies shipped 21 million prescriptions of painkillers to 2 pharmacies in a town of 2,900 people. That's criminal in my view. I could say more, but I won't. There's a lot of people to talk.
Yeah, I will welcome anyone to jump in. I'm going to ask questions to each of you, but feel free. But I'm going to pass the baton to Dr. Perrone because you're on the front lines of this epidemic. I'd like you to tell us, and I'd really be interested, this affects all of us. And make no mistake about it, there's nobody here who doesn't have somebody who's been affected by this crisis. So I'd like to know from your perspective, because you're on the front lines, what does this look like from the perspective of an emergency room clinician who specializes in understanding and treating this problem?
Yeah, so I feel like partly I'm the only physician, I think, on the panel. So I want to half defend and half support what you're saying, because I think absolutely the drug companies, perpetuated this concept that opioids were safe when they absolutely were not. The FDA propagated that even further and supported, prescribing. The Joint Commission, all these federal regulatory bodies fell into the very convincing campaign that the drug companies came across with, saying that these drugs were safe and that we really had a responsibility as physicians to not let anyone suffer at all. And that we must make pain, that pain is perceived as a score of 10 out of 10, we need to get it down to 0. And so that created this cycle. When I trained, in the early 90s, we didn't prescribe like that. And I watched it happen, between 95 and 2005, where we were just pushed to prescribe. And it happened across the board.
So you actually saw that happen?
I saw the whole thing evolve. And it really wasn't until, mid-2000s when we said, and in the emergency department, because what we would see is people would come in, they had become addicted because of the therapy that was being prescribed in an effort to treat pain. But someone said the same thing, that opioid dependence and tolerance happens very quickly. You need escalating doses immediately. If you think about the story of the amazing singer Prince, right? Mm-hmm. So Prince was prescribed opioids for a condition acutely, which was just a musculoskeletal injury, but he rapidly became dependent and tolerant. Over time he developed aberrant behavior. His family maybe said, you're using too much, we don't want you to do that. So then he had to get a little secretive about it, which is the beginning of addictive behavior. But because he was, had money and resources, people were still prescribing to him. So he wasn't on the street necessarily. A week before he died, he had a fentanyl overdose, which people may know about. That was a time we could have intervened and saved him. But his family was facing stigma. They tried to do it in a secretive way. All these things happen to people in the United States every single day. And then lastly, he died of a fentanyl overdose, which is exactly what's happening in Philadelphia. So that is the paradigm from beginning to end. What we're seeing in the emergency department now is picking up the pieces of the 220 million prescriptions that 5 or 10% of people get addicted to. So we see overdoses, we see people who don't get revived from overdoses, and we see people who are seeking treatment, and that's a lot of what we're working on now.
So Mayor Kenny, your administration has declared, and I'll quote on this, Philadelphia is facing the greatest public health crisis in a century. And you've aggressively sought to stem the deaths with some notable success. So how has the Philadelphia Resilience Project work? What lessons can we learn from it?
I think the biggest lesson that we've learned is not to criminalize addiction, which is what happened in the 80s and 90s with crack. We tried to approach this multi-agency-wise. Police, of course, are on the front lines, health department, behavioral health department. Streets, actually things like sanitation and other issues that you wouldn't think directly related to opioid addiction or heroin, mostly heroin now. When they get to the street, it's mostly heroin. And we had people living on train tracks for almost 15, 20 years. It's Conrail tracks, and they were down in the gulch, so you couldn't really see it. The neighbors and the elected officials there wanted that cleaned up and moved and secured, which we did. It took a lot of time and a lot of money to do it. And finally, we cleaned up the tracks, put up a security wall. I want to say wall, sorry. Security fence, slats. There's like slats.
That's good.
It's not funny because we're dealing with this serious issue. And then what happened was that people were moved, and then they went and encamped under 4 train trestles near the tracks. Now we just can't, and we're not going to do this. We just can't drag people away. I mean, it's not legal. It's not constitutional. And people started, and well-minded people, well-intentioned people, started bringing tents and heaters and fans and all kinds of things, which kind of entrenched them even more. We've cleaned up 2 were easily dealt with. 2 more were more intractable. The 4th one we finally did get rid of. But in order for us to do that, to clean up the area, we need to offer people treatment beds. I think the last time I looked, we had 160 people either in housing or in treatment. We have police-assisted diversion. Instead of taking people to a station house, they pass them off to one of the addiction services or to a hospital or to some place that can take them, because we don't want to lock people up. It makes things that much worse. And we're doing our best. Our overdose numbers are slightly ticking down. We spend more money on naloxone than I ever anticipated. I didn't even know what naloxone was. And thankfully it's there. Librarians have it. Recreation department workers have it. Police all have it, of course. Firefighter, paramedics, everybody has it and access to it.
Something about
naloxone? Yeah.
So how many of you all are carrying naloxone? So Narcan or naloxone is more likely to save lives than any of you who are trained in CPR. So the police carry it now, the ambulances carry it, and all of you can carry it as well. So this is a real opportunity in our city to save lives.
So how do you administer it?
So this is
Might
just
as well do a little
just a little device. This is a Narcan nasal spray, and if somebody is unresponsive, it just goes right up their nose. There's no needles, there's no injections.
And you press.
It's very safe, and you just depress it, and it atomizes a antidote that can save lives. So
and just criminalizing it is making people go to jail because of this just fills our jail. I mean, our jails now are filled with people with mental health issues and drug issues, and they're not equipped to deal with that. There's no easy answer to this, but that isn't working. Go ahead.
I know I get beat up on the crime bill, but what the crime bill did, it put in drug courts.
Yeah.
It put in drug courts that a lot of police departments won't use. A lot of states don't use. They'd rather lock people up than divert them into a drug court to move them from instead of going to a prison, going to a treatment facility. And I think we have to do a whole lot more of that diversion in order to have some impact on what we're going to be able to do.
But really,
the other controversial issue that we're dealing with.
I love the fact we're getting quickly just here to some things that actually can be done.
We're dealing with a very difficult issue, very controversial issue with the overdose. We call them overdose prevention sites as opposed to what we didn't call them. There's 120 of them across Europe and Canada. It's very, very difficult to explain to neighbors that this is a good thing because we are saving lives. We won't operate it. If it opens, it'll be operated by a separate nonprofit, but we'll have our social service people and other folks there to be able to hand off those folks to us.
Terrific. So, Governor Bush, I have to applaud you. You were one of the first leaders in our nation as governor of Florida to call attention to and actually start dealing with the crisis. You declared the opioid epidemic a national emergency very early on, and as Florida's governor, you had to address addiction issues across our third most populous state. And I would like to know from you what the challenges are in addressing this epidemic in diverse communities, ranging from Miami to Pensacola. You have an incredibly diverse state, and you addressed it. So what can you tell us about what's effective?
Well, first, I don't want to contradict the president of the University of Pennsylvania, since I'm a professor of practice, and she could probably fire me. But in your introductory remarks, you said that we consume a third of the painkillers. We consume 85% of the painkillers in the world.
Oh, that is news to me. That's amazing.
It
so
brings
if that
to bear
wasn't
that
shocking enough,
it's just
that's why we have professors, right?
It's breathtaking. The cultural, at some point our culture needs to recognize that that's way over the top crazy. That zero pain is look, we're, as a human being, we're going to have joy and we're going to have pain. You can't level it out to have something that is incredibly boring. I mean, life's full of ups and downs, and that's the pursuit creates a purposeful life in so many ways. So I'll leave that aside because there's no solutions there other than recognizing that that's a challenge. In Florida, I had a personal experience with my daughter that had significant issues related to mental health challenges as well as addiction issues. So one thing I'd say is that they normally go hand in glove. They normally go together. The mental health challenges are hard to see. You have a problem with, your ribs bruised, you can take a pill to alleviate the pain. When you're seeking drugs because you have schizophrenia or some other disorder, it's a lot harder for doctors to diagnose, and people spiral out of control. And so I think one of the things we need to do as a society is to talking about moon launches, Mr. Vice President, a launch of the brain might be one of the things that we should do to really study the brain to try to understand it better so that people don't spiral out of control and become drug seeking. But really, because of seeing this challenge all across our state and then being motivated by my high publicized daughter's challenges, which were really, really hard for my wife and I, we committed ourselves to create a strategy to deal with this. And I guess the advice I would have for people that are focused on this, similar to what the mayor said, is that it's got to be comprehensive. It can't be one thing. Prevention is a key element of this. It's not cool to take drugs in general. There ought to be a higher understanding of that and the path that leads. You need to fund treatment, and it needs to be research-based, because there's a lot of treatment that doesn't work. I'm a big fan of focusing on, we didn't do this in Florida, but other states now are doing this. I think in Pennsylvania they're doing it, certainly in Massachusetts, of recovery professionals that need to be certified as such, because this is a long-term issue. You can deal with this in a 30-day treatment facility, but this is a lifetime challenge for people that are addicted to drugs and alcohol. And there are real professionals, but we haven't created the certification process to recognize them, and federal funding doesn't flow necessarily because of that. And then I think you need to get law enforcement more engaged in a comprehensive way. We're a bottom-up country. We have more police officers in Philadelphia than the DEA has, probably agents. But there's very little coordination. So I'm a big fan, and we used them in Florida, the high impact, whatever the rest of the acronym is.
High intensity drug trafficking administration.
Washington comes up with these acronyms that are like, they don't want you to know what it is, so they created an acronym. This one's one that works.
Is that the reason?
That's my theory. I don't know. I could be wrong.
That's as good an argument as any.
But that's very effective. Right. When you have, in New England, you have 5 little states, and if you can't coordinate in terms of law enforcement to keep the heroin out of the communities and keep fentanyl out of the communities, you have to have the federal government be actively involved. The final thing I'd say is that as it relates to drug treatment, Washington provides a significant amount of money, but they have so many strings attached. There's 56 different drug treatment programs that Washington funds. And I would think maybe one flow of money and allow the states and local and large urban areas to create the strategies, because we're on the front lines,
Yeah.
particularly mayors. They're on the front lines. They're the
I
ones
think you have
dealing with
one
this.
person here who would certainly agree with
And
you.
then measure it.
But we're all nodding. Yeah.
Measure it so that you can see if it's successful or not, and if it's not successful, stop funding it, for crying out loud, and reward success when it's working. The final thing I'd say to validate what the Vice President said, Florida was the first state to create first drug court in the United States was Dade County, where I live. Janet Reno, state attorney, did that. And under my watch, we created drug courts throughout the state. We're the first state, at least of scale, to do that. And it is phenomenally successful.
Exactly.
So I think everybody here needs to yes, let's. I think it's incredibly important that all of us here take note of these things, because as concerned citizens, we can actually use our voice and put pressure on public officials and drug companies and to fund what works and don't fund what doesn't. So you said something very important that actually Professor Madras has worked on a lot, which is the connection between mental illness and treating mental illness and drug prevention, and how you actually reduce demand. How do you, it's one thing to treat, and it's quite another thing to look at what causes this and try to find how you reduce demand. So, Dr. Madras, you have really, Professor Madras, you have really devoted a large portion of your career to demand reduction. Can you tell us something about what you think works and what's happening or not happening in this regard?
Let's just dissect the word demand reduction into three components. It means prevention, intervention, and treatment. Prevention is a multifaceted organ which includes supply reduction, which means fewer prescriptions, fewer first exposures to opioids. It also includes understanding who is at risk for substance use. We know without a shadow of a doubt that children who come from abusive homes, 50% are likely to become addicted to drugs, and the severity of their addiction is higher than others. So we have to understand that a lot of this begins at home in families. There's also a contagious factor. Parents who use drugs, their children are much more likely to use them. So that's part of prevention. Prevention is understanding what the risk factors are. Prevention is including supply reduction. The second phase of this is intervention. Intervention means trying to understand who's using, who's at risk, and how to intervene before they progress to addiction. And the first thing I did when I was at ONDCP was take a flight to Chicago to the headquarters of the American Medical Association. And I spoke to the executive director and I said, I want to medicalize addiction in our country, bring it back into the high quality standards of medicine, which we certainly did not have at that time. And he responded by saying, we take care of alcohol and smoking in medicine. We can't take care of all human problems. And I said to him, you are prescribing prescription opioids, and we are beginning to develop a vast problem with addiction and overdose deaths to the prescriptions that you as a medical community
When
are.
was that?
That was in 2006.
So that was already when the medical profession was part of the problem.
They were part of the problem, and his response was, at that instant, slamming his hand on the desk and saying, you've got me. I understand. And as a result of that encounter, I said, we need billing codes for physicians in order for them to screen for people who are on the path to addiction, may not be there yet, but they're engaged in risky, problematic, and to screen for people who are misusing opioids. And at that point, I got an invitation to their CPT board in order to get billing codes. The final component of demand reduction is treatment.
Yeah.
And the problem is we have 14,000 treatment centers in the United States, of which less than a third have quality treatment. And we have to do a lot better than that. And we have to bring those into the domain of the medical community where the standards for outcomes, for continuum of care, for quality care are much higher.
Can I make a comment?
Please.
The governor's dad was president when I wrote the office of that combined all the agencies and to work together on drugs. And this is a question I have for everybody. What I found was, I got stuck with it because I was chairman of the Judiciary Committee, writing most of the drug legislation that occurred in that period. Big mistake was us buying into the idea that crack cocaine was different than powdered cocaine, and having penalties. It should be eliminated. But one of the things I found most difficult is in private, when you talk to your colleagues, and I talk to my colleagues, whether they're in state legislatures or governors or senators or congresspersons, they really do not buy into, they say they do, that addiction is a disease. They think it's willpower. One of the reasons why people are not willing to spend the money that could be, in fact, incredibly useful in reducing demand, incredibly useful, is because, well, you should just have the willpower to do that. And one of the things you've done, Doc, and you've done, is begin to convince the American public that this is a disease. It's a disease of the brain. And the thing that the governor talked about in terms of the brain, one of the things we did in our administration was we set up an entire initiative at NIH called the Brain Initiative to study the brain, spending $1 billion just to study the brain. We know less about how the brain functions than what's at the bottom of the ocean. And so could you speak to that just a second about the idea of addiction versus willpower?
It's an excellent question. Addiction is a biobehavioral disease, which means that the brain undergoes vast changes after the influence of drugs because the drugs produce signals in the brain that are so abnormal that the brain adapts. And once you remove the drug from the brain, the adaptation takes over and you no longer feel normal unless the drug is reintroduced into the brain. So that is a very simple way of looking at it. The operational definition of addiction is compulsive, uncontrollable use despite adverse consequences. But that's a behavioral definition. It's not a biological. The problem is, for many people, is that people age out of addiction. They may have an alcohol problem, they may have a cocaine problem, but if you look at the data, you see this upsurge of addiction that occurs, and then it just declines as a function of age. So people say, if people age out, if they quit smoking cigarettes and they don't need even to go to rehab, then why are we calling this a disease? The problem is that may be true for some people, but certainly not for others.
Some people age out by dying.
Some people age out by dying, but there are many people who have such severe, profound brain changes that unless you help them, in the case of opioids, the help is with certain medications, you cannot really climb out of that uncontrollable urge. Now, for many addictions, and we should not only be speaking of opioids, we have many drug challenges in our country. 50,000 died last year of opioids, but 20,000 died of cocaine and methamphetamine. What we have is no medications for many of them, and it is clear that behavioral control, volitional control is part.
Yeah.
It is absolutely part of treatment.
So Dr. Perrone, we know there's a lot of stigma surrounding opioid use disorder and even greater levels of misinformation out there about treatments that are evidence-based and those that are not. What are some top facts that you would want everybody to know that would really be useful for us to know and take not only to mind but to heart when in our roles as concerned citizens and professionals?
Yes, thank you. That's such a great opportunity. There is treatment. There are medications that help substantially. These are not medications that, there are some medications that are stigmatized. There is the drug methadone, which is a full opioid agonist, so it acts like heroin. Some people say it's like an addiction, one addiction for another, but that's completely untrue because it stabilizes the brain, like Dr. Madras said. There is a need to replace that drug that's been taken away, but it prevents the addictive behavior. It prevents that behavioral impulse to go out and seek the drug, and so they can stabilize, they can work, they can go, back to their families, they can take care of their kids. So methadone is an amazing drug that has been around since the late 1960s, but it can only be available by going to a treatment program every single day. It's highly regulated. The government was very concerned when that became approved. In 2002, another drug got approved, which was called buprenorphine. I'm going to call it Suboxone, which is a trade name, but Suboxone is another very viable treatment for opioid use disorder. The problem with Suboxone, or first I'll tell you the benefits. It works like methadone, except it's safer. It's not a full agonist, it's a partial agonist, but it has a ceiling effect. So it prevents people from overdosing, but it also prevents them from using heroin or fentanyl. So it's tremendously helpful. And what we're doing in our emergency department is we want people to get into treatment. People can't make appointments when they're going through the cycle of withdrawal and craving and using. So they can't get into treatment. So we need low barrier treatment. And what we have done is we've started from our emergency department getting people into treatment by giving them buprenorphine when they come to the emergency department and they're in cycle of crisis or seeking treatment. We can start them with their very first dose on that visit. And that makes a huge difference. But in concert with that, they need support. And the advocates that we have, Nicole and Bryant, two people that I've been working so closely with in the past couple of years, are amazing. They're certified recovery specialists. They take that patient's hand and they guide them to their first appointment, to their treatment. Nicole just drove a patient to a inpatient treatment center last Saturday morning.
Nicole, will you stand up? So yes, yes.
So, as Governor Bush said, certified recovery specialists in concert with medications, there is treatment. So the stigma of AIDS 10 years ago, 15 years ago, was that there's no treatment, so people were keeping their family members at home. There is treatment, we can help, but we need resources and opportunities to get to these patients.
Part of the difficulty from local government standpoint is the siting of the locations of these facilities. No one wants them in their neighborhood. The people who are living in neighborhoods that are suffering from, the non-addicted people who are living in neighborhoods suffering from the scourge, don't want the treatment facilities anywhere near them, but that's where the people who need the addiction services are.
So one acronym I bet a lot of people have heard of is NIMBY, right? How many have heard of NIMBY? Not in my backyard, right?
But legitimately they're scared. Legitimately,
right.
they're in the epicenter. They're in the center of the core of the
Absolutely.
problem, and their kids are in the center of the core of the problem. We actually put up needle disposal boxes near elevated train lines, exits and entrances, so we could reduce the number of needles in the street. When we do cleanups, we've done 4 major cleanups in Kensington and Fairhill in the last year. The number of discarded needles is just amazing. And people when they're walking their kids to school are just scared. And what we've tried to do is we try to find facilities that are somewhat enclosed campuses, whether they're like a community hospital, things of that nature. But again, with the overdose prevention site, that is extremely controversial and extremely frightening to people. And the other issue is that people at a meeting just the other night were saying, well, if we put one of those in our neighborhood or we allow it, are we giving up? Are we just throwing our hands up and letting people inject illegal substances without any consequences? We have to explain to them that when the person comes to a facility like this, in addition to being able to inject relatively safely and not overdose. There's showers, there's lounge space, there's space to interact with social workers and addiction specialists. There's the opportunity to get your arms around them and to try to get them into another place. You can't do that when a person's under a train trestle in the dark, by themselves. We just have to pick up the body at the end of the day.
So another fact that people have to take to mind and heart is that there isn't one single simple bullet solution. That's part of a larger program that's needed here.
First of all,
Governor.
I would add a little context to this. A lot of the people that are suffering with this addiction aren't living on the streets. True. I mean, a ton of them. I mean,
Right.
My ill-fated run for president, which I recommend people do that if they're thinking about it. About it, Mayor? I was talking about
just a little advice.
about the mayor, but that's
Right. Just a little random advice. Well done.
I'm looking for a beach.
my first trip to Manchester.
Speaking of addiction.
First trip to Manchester, I met the receptionist at the Hilton Garden Inn. Her daughter died of an overdose. The waitress at this tiny little restaurant that I was with the mayor of Manchester, and he told me that she had a son that died of an overdose. And the guy that traveled with me throughout my time in New Hampshire, his brother died of an overdose. Yeah. Literally within 2 hours, I met 3 people whose families, are going to be altered for the rest of their life, and they had 3 deaths. There's a 20% increase in foster care in places where, in West Virginia and other places where the most severe outbreak of this epidemic exists. And so my point is, this is a national challenge. If we marginalize it to the most, the most vulnerable, the people that we see sadly on the streets, which is something that I applaud local governments doing what they have to do. I think we missed the point that this affects a broad number of people. And I would add another thing, this may be a little off field, but there's a problem with alcohol abuse and the public health challenges that deal with alcohol is even probably from a health perspective has the universe of people that deal with that issue and the families that deal with that are extensive. So if we're focused on the public health challenges of addiction, I think we need to look at it in the broadest possible way.
Every socioeconomic background, every race, every creed in this country is affected by this. Mr. Vice President.
I want to ask my elected colleagues this. Do you guys find that...
There's only one of them.
See, I don't need to ask questions.
those of us who run for office.
Oh, okay, it's different.
You're a hell of a governor. One of the things I find, and I suspect you're still hearing, so many people come up to us and ask for help, from literally the husbands or wives of millionaires to people on the street that are. And the thing that I most often get asked is there any treatment? Because how many of you know someone, and raise your hand, who sought treatment, went to a facility where the recovery rate was 1, 2, 3, 4, 5%, that virtually did nothing for them? Raise your hand. How many of you know people? I mean you, I mean just the people you know. And so one of the things you talked with me about backstage, Doctor, is there a way to get to a certification level where people can identify treatment facilities that really have some muscle to them, have people who know what they're doing?
Nowhere to go that work.
I mean, so, at Penn, at the hospital, we have to report our successes in cardiac surgery. There would be no reason why we wouldn't mandate that a rehab place would look at the outcomes of their rehab. It is a difficult disease to treat, but if you have failure rates that are in the range of 80 to 90%, part of that is the disease of addiction, and that's what they're hiding behind. But part of it is, not having to follow those outcomes. So absolutely, we definitely need regulations and outcomes and more visibility. Because what happens is, everybody with private insurance and extra money pays thousands of dollars, hundreds of thousands of dollars to get their kid into one of these treatment facilities. And on day 31 or at the end of 6 months, they're still walking out looking to use. They just don't get better, unless they're getting evidence-based treatment, which is these medications or a combination of treatments.
So I want to ask a question that we haven't touched on here, but it's in the news a lot, and it's another one of those really complex issues that I wonder if, particularly if our public officials, what your views on this is. A substantial factor in this epidemic is said to be all the illegal drugs coming in to our country from abroad. So they include powerful synthetic narcotics that make their way into less powerful drugs, which are leading, we're told, to a spike in overdosing. How are we doing in detecting and intercepting illegal drugs, and are we doing as well as we can do, or anybody who knows about
it's really
this?
hard to, we're not doing as well as we can do. It's clear because we have the problems so pervasive. But our police department works very closely with our federal partners, the Department of Justice, the FBI, ATF, and all of the agencies, and they do a good job, and they work very well together. And there's been a couple of large interdictions and drug busts in the last number of months. I think part of it is on a larger global scale. From my understanding, correct me if I'm wrong, much of the fentanyl comes from China.
Yes.
Having the ability to negotiate these kinds of deals, international deals, to get the Chinese to crack down on it at home, I think is another answer to the problem. By the time we get it, we're on the street. We're under the L,
right.
And it's hard. And the other issue is that for people with a small possession of a small amount, what do you do with them? Because then what happens?
No, by that time it's already in.
So I'm kind of at the lower end of I think maybe a governor has more ability to.
What at the state and Mr. Vice President, what do you see that we are doing, and what more could we be doing here?
I spent 5 years of my life working on this particular issue, and we ended up with the commission that Doc worked on. There's 3 things we can do. One is we can, and it's all demand driven, so we can negotiate with the countries of origin of the material that they're sending in. We did that fairly successfully with Colombia early on.
We did the Colombia plan and the Merida.
And I put together this plan called Plan Colombia. It wasn't very, very well greeted at first. But what we did was we went in and we actually worked with their law enforcement. For example, we did lie detector tests. We brought our FBI down to Bogota. There were over 7,000 federal police. We were able to get to the point where we convinced them to fire almost 5,000 of them. And we helped them hire non-corrupt elements of the police departments and it had an impact, didn't stop everything. In China right now, China made a commitment to our administration and reinitiated the commitment to this administration that they were going to regulate all elements of fentanyl. There's various degrees of which it constitutes, whether it's how much of a problem it is. But what we can do, most of the fentanyl is coming from China, but it's also going through Mexico. And the vast majority, as you learn in these trials of El Chapo, who is a drug lord, it comes through legal ports of entry. And one of the things we argued for a long time, but it's very expensive, and that we have the ability to have these large, look like containers that are X-ray machines that you literally drop over top of an entire tractor trailer. and you can determine the density within that trailer of what's in the trailer. For example, if it's like the largest drug bust, they was carrying cucumbers, but they found all this fentanyl in the bottom, because they could tell by the density it was something different. Well, we have 37, 38 ports of entry. We're now up to having 34 of these big machines, but we need probably 3 times that many. But the administration and we didn't do enough either, resisting the cost of them, coupled with the fact they need at least 4 people operating them. They're very expensive to operate. But I'm not being a wise guy about the wall and the president and all that, for real, my word. But instead of building more barriers, if it's drugs you're talking about, we could take 1/10 the amount of money we're talking about building on a wall and significantly increase the technological capability at legal ports of entry, because that's where 95% of all the stuff is coming through. And so we can, A, negotiate with the countries in question and have consequences for their failure to cooperate, as well as have a significantly more sophisticated technological capability and additional personnel at the ports of entry.
I think there's more than that. One of the interesting things in 2006 is that there was a super lab in Mexico, in Toluca, Mexico, that produced all the fentanyl that killed 1,000 Americans at the time. When that super lab was taken out, the fentanyl deaths went back to near 0. So that was a point source. We now have at least 5 point sources from China.
Yes.
And one of the things that our government can do is number one, do the type of tracking that Federal Express does, which our postal system does not do. And the second issue is we can use our vast economic leverage with China to have them enforce their own laws on fentanyl production. And that is one way to squeeze the Chinese government into curtailing production.
Because a lot of it comes through the Postal Service from China, directly from China.
Yeah.
But if the same package came through Federal Express, it has a different method by which you can check it out. But not for all postage coming out of China. You could do that.
Governor Bush.
I would just, I was going to say the exact same thing. The Postal Service is treated differently than UPS and FedEx, and there's a bill in the Senate, I don't know where it is in the House, to change that, to raise the standards. It costs a little bit more, but fentanyl is such small quantities, creates such dramatic impact, we have to do it. And we're in the midst of negotiating what, being an optimist, I hope this happens, a new trade arrangement with China that is really essential for, it'll be a big deal if it happens. This should be part of that, and there should be no lifting of any kind of tariffs until it happens. This is a national problem. They can solve it.
And can this be a bipartisan? Can this be a bipartisan?
Well, by the way, that legislation passed. And the deadline was the end of 2018 to implement it, but the administration has not implemented it now. It was supposed to be implemented, dealing with postage.
They raised the goddamn stamp to 51 cents. No, this is an outrage, and they can't do that.
But it has not been implemented. That's the problem. The administration hasn't implemented it.
Well, that's a big deal to implement this. Let me ask you, Governor Bush. You implemented a multifaceted strategy when you were governor. What do you think governors today can do that would be most effective? What would your advice be here?
Well, first of all, a lot of governors are doing this. This is a number one issue in most places. So New England was the place where this impacted, was the quickest to hit, and so the governors of New Hampshire and certainly Massachusetts, Charlie Baker has done a phenomenal job building grassroots support from the bottom up to create a comprehensive strategy. Ohio is another place where I think there's been a lot of great work. So I'm relatively optimistic and confident. And you're seeing a decline in the number of overdoses with prescription drugs. Sadly, fentanyl now is the place where there's been an increase. So This is a never-ending challenge. I think looking at this in a comprehensive fashion is part of it. The one place where in Florida there was the most dramatic impact of restricting prescription drug illegal use was the prescription drug monitoring system that was developed. That was not during my watch. In fact, the legislature rejected it like 4 straight years because of civil liberties concerns, but they were wrong. And the minute it got implemented in the last 4 years, we went from South Florida being the pill mill capital of literally of the United States to getting it wiped out entirely.
Wow.
So dealing with prescription people, drug-seeking people find the pharmacists that are prescribing illegally. Medicaid is the principal source of reimbursement for a lot of this. We have the ability in this country to know when people are overprescribing exponentially more than they deserve. And the hammer ought to be brought down on them like nobody's business. It shouldn't take 3 years for investigation, because during those 3 years, my frustration as governor was the U.S. Attorney's Office, methodically going about their business, didn't let us go and take the guy's license away as he was overprescribing. And we had to pay the consequences of a lot of pain and suffering in families. So I think accelerating these, the law enforcement prosecution of this stuff, there's just a handful of doctors that open up this market in a way that provides the illicit drugs.
Yeah, and I think that's important point just for us to know, because while doctors are a source of this problem, it is a tiny fraction of the doctors. Most doctors do and want to do the right thing, but a tiny fraction can make an enormous.
Part of it is education.
What?
You have to educate these doctors in these communities who are neighborhood docs on the corner. You have to really go out and talk to them and explain to them and give them information, because they don't always, you assume they're doctors, they're smart, they know everything. Well, they don't have all the information. You do. But they don't have the information, and we've done that with our health department, going out to individual practices and giving them information, engaging them, and explaining what role they can play in a positive.
The other thing that states are doing I don't know if it's every state, but every state should do it, is to limit the first prescription to 7.
I had surgery a couple years ago, and I left the hospital, and they handed me a pill bottle with 30 oxycodone.
Yeah, it's
ridiculous. What am I going to do with this? I mean, and then what happens, I think, sometimes when you don't need it anymore, so you take 3 or 4, and then you're fine. You got a Tylenol 800, and you're fine, and a glass of wine, and you're good. But it sits in your medicine cabinet. Yes. And if you have children in the house, that's where some of this stuff starts.
Doc, you cited a statistic but I think it's important to know. I mean, I don't think doctors are bad. They're good. They're trying to save lives, but it's kind of willy-nilly. I remember reading a report where you said of the people who show up in the emergency room with a sprained ankle, 25% of them get an opioid prescription.
That's really.
What the hell is that about?
Yeah. So it was actually.
That is malpractice.
Right. But we found that we did a geographic study across the country, and the range was something like maybe 5 or 10% in Nebraska and up to 40% in Alabama or some southern state. So tremendous variability, and that was for uncomplicated ankle sprain. And so that is egregious prescribing, but that is the result of a generation of doctors starting in 1995 who are now 2015, 20 years of practice where they were tuned into this pain score.
Zero pain.
Not only that, but also patient satisfaction scores. You rate your Uber driver, well, they now rate doctors. So nobody can afford to have a 4-star rating when everybody comes down on you for, not having a 5-star rating. So.
But how about hospitals in pain? No, what I'm serious. Hospitals get rated, and the patients determine when they leave the hospital, did they leave with pain? Yeah. Well, one way to make sure your rating stays up is make sure you don't leave with pain. I can guarantee you're not going to leave with pain if you're taking an opioid.
But the good news.
Serious. Why don't we talk about this?
The good news is that there is a 50% drop in new opioid prescriptions for drug-naive people, which is excellent news.
Yes.
And the other excellent news that I believe is that the physician prescribing issue is solvable, and it's getting solved. I don't think that that's where the future of policy lies. The future of policy lies in the new psychoactive substances, fentanyl analogs, of which there's 1,000 possibilities in fentanyl.
Yes. So let me ask, because I have time for one final question. We're going to do a lightning round down the row here, and then we're going to open it up. I have some questions from the audience. The final question is, if you could have all Americans know one thing that is misunderstood, or take one collective action, what would it be to help solve this problem?
My first priority would be to not introduce drugs into the developing adolescent brain, because that is the kicker.
Amen. Amen. Governor.
If I had a fairy godmother land on my shoulder and, and give me any wish, it would be to change our culture so that we don't default to taking a pill to resolve our problems, that the way to solve our problems is to solve them.
Mayor, do you realize we have professor, governor, mayor, doctor, vice president? What more could you ask for? Mayor Kenny.
Substantially more financial help for local communities to deal with this problem. And we're
Yeah. So we may spend more than any other country, almost twice as much per capita for health care, but we vastly underspend for mental health, for drug problems, and for public health. So vastly underspend.
I mean, we're going to spend $36 million in this next year over the next few years in dealing with this issue, plus police overtime, all the other issues that affect trying to manage it and deal with it. Every time I think of spending money on misery, which like the misery dollars, I think of spending that money in schools, in facilities, and infrastructure, in transit. There's so many other things we can spend money on, but we have to spend the money to save people's lives. So we have no choice.
Dr. Perrone.
So keeping opioid-naive people opioid-naive. Nobody should take these medicines for treatment 1, 2, 3. There's alternatives in almost all cases as first, second, and third line, and we just need to prevent people from getting started in most cases.
Can you add on that? Because I know we talked before we started about what are the role of places like CVS and Rite Aid, the places people actually go to get their prescriptions fulfilled, and now more and more are opening storefront
those storefront places are dangerous because they want to get you in and out quickly, and they still have that perception that patient satisfaction is driven by receiving an opioid prescription. Like, you take your kid to the doctor for an ear infection, people think that you want antibiotics. You may not want antibiotics, but the doctor's perception might be that you want antibiotics. So, instead of just giving them the prescription, having a discussion, but that takes, 10, 15 minutes instead of 1 minute to write a prescription. So it's much easier, but wrong to go the easy path. So we need to go the harder path, education. Don't take these drugs if therapeutically, when there's many very effective alternatives.
Mr. Vice President.
Little pain's not bad. I would point out, I would wish if everyone went to sleep tonight in the United States of America and woke up understanding how addictive Percocet is, how addictive these painkillers are. They don't understand it. They don't know how addictive it is. And not everyone who uses them gets addicted, but a significant portion do get addicted. And people just don't know it. So when the pharmacist or the doctor or the hospital, as you're walking out the door, you have great faith in them. The one place we still are reluctant to question is our doctor, of all people. And he hands you a little plastic bottle, and it has 20 Percocet in it. You have to believe it must be right. And I don't know, because I've been through this a lot. I've been a great consumer of health care. No, I really have. I hospitalized for 7 months myself in ICU, lost family members. I spent a lot of time in hospitals. And I want to tell you something. I've not seen any doctor say, now look, you understand this. If you take this could be really, really debilitating. Do you understand? And by the way, try Advil first. By the way, not a joke.
It happened to me.
No, but-
I was in the hospital, and I was on Dilaudid, which is
Yeah.
kind of,
Everyone's looking at me like I prescribed it.
I mean, it's kind of fun, you know. But the nurse came in, and she said, "Honey, you like that button too much, and you're coming off today."
Good for nurses.
Good, that's very
nice.
good for that nurse.
Anyway, for people to know how addictive it is so you can make a rational judgment. A rational judgment about how much the pain is. If you're thinking that I've got this pain, but if I take this for 5 days, I may be one of that percent that in fact becomes addictive. You make a rational judgment, assuming you don't have other problems already. But people don't know.
Yeah. Well, there is a problem in this country called generational forgetting, because we had a terrible opioid addiction epidemic starting in the 1820s, and it lasted until 1910, until the federal government intervened. And we forgot.
And what did the federal government do?
They forbid physicians from treating addiction with morphine. And they said,
That makes sense.
Yeah. Yeah.
Brilliant.
and what was fascinating is that from 1914 on until 1990, I would say that was a precipitating point, there was an opiophobia amongst the medical profession.
Bingo.
And then it went into opiophilia because nobody learned
Remembered.
the history.
And the morphine became because of the Civil War.
No, much earlier.
No, but it really hit with the Civil War. That's where it was being prescribed, overwhelmingly prescribed, and it was viewed as an answer.
Yes, but until then it was women who were most affected by morphine addiction.
So we not only right here have addressed what some of the things that can be done, but also how important it is to remember when we do things that are effective and keep, as Mayor Kenny said, the education going.
Yeah.
Hence this panel, but now is the most important part, whereas we have questions actually from our audience. And I have these questions, and I'm going to throw it out to any of you to answer them. But I'm going to ask if the person in the room who wrote this question would stand up. Her name is Caitlin Crane, and she's a nursing student. Caitlin, are you here? Can we just... All right. Great. So Caitlin's question is as follows. How, and by the way, I have to say, because Caitlin's a nursing student, I assume, are you a Penn nursing student? Well, you should all know that our nursing school is ranked #1 in the world. Not to brag or anything,
Of course it is.
and we really care.
If there's any angels in heaven, they're all nurses, male and female.
Correct. How does the current state of mental health care influence the opioid epidemic, and what can we do? Who would like to begin?
Well, I think there has
Why don't
to
you
be-
say what you're affiliated with, too?
I am currently at McLean Hospital, which is the #1 psychiatric hospital in the country. I think one of the most important issues we have to introduce into addiction, into primary care, into most branches of medicine is mental health screening. Because mental health screening, whether it gives rise to a diagnosis of a severe mental illness or a mild mental problem, is a cofactor, it's a precipitant of drug use. And if you don't treat the mental health condition, it's very difficult to get people who have an addiction to drugs to be treatable as well. You have to do both.
Anybody else? Yes, it's very, very important. Anybody else want to address that, Mayor Kenny?
I do think in general, whether it's addiction or just mental illness, the police departments in our country need to train our officers to deal with people with mental illness, and we do this here. You know, so many times in around the country, people wind up being shot by a police officer because they don't know the protocols of how to deal with an individual who's going through a crisis. And we were very, very pay attention to and train our officers, both in the academy and on ongoing education, some methods of dealing with people who are going through this this trauma.
Yeah, I know that our Vice President for Public Safety, Maureen Rush, really believes in this, and Maureen is here. Thank you for all you do. Any other answers to this? Okay, next question. Will Adams, Wharton student. And of course I have to say, Wharton is just been ranked unrivaled the #1 business school in the world. So thank you, Will. So here's Will's question. How can we balance short-term emergency response with long-term solutions to the opioid epidemic? So how do you balance the short-term response with the long-term solutions? I think that's just a critical question. Yes, Dr. Perrone.
So I think we're distributing naloxone around the city, and that is the short-term response, right? We save lives. But you should know that about 10% of the people who are resuscitated with naloxone are dead in a year. So if we don't get them into treatment right from that moment, we're losing an opportunity and people are dying. And kudos to the mayor and EMS. The city has now started a new program where when patients are resuscitated with naloxone, but they don't want to come to the hospital, something called an alternative response unit comes to the patient side with social workers and certified recovery specialists to try and get them into treatment. We cannot miss these opportunities. So acute resuscitation needs to be followed by treatment intervention or just engagement, just connection to care with people who are peers who can speak to the patient, say, you know, I've been there, I know what you're going through, I know now might not be the time, but you know, next week or next month, come back.
We have to do both. We can walk and
absolutely.
chew gum at the same time. We have the resources to do it.
Any
Walk and
other
chew gum.
things on long-term? Mr. Vice President, what do you think the most important long-term solutions here are?
I think two things at the same time. Actually, three things. One, what the governor talked about, is significantly more scientific research on the brain and determine how this functions. Number two, I think to deal with the thing that gets people engaged in the first place, and that is determining whether there is something in the brain that generates this kind of behavior and or the way in which we distribute these drugs is a second piece. What gets people hooked in the first place? And thirdly, once they're hooked, to spend a great deal more time, energy, and expertise. We should be incentivizing our drug companies to find alternatives to the opioids they're producing now.
Can I ask the doctors a question?
Sure.
What's the research say about the use of cannabis in an effort to reduce the
If anyone
severity?
doesn't know what cannabis is, it's AKA marijuana. But let me just say one point about that. I'm not going to answer. I'm going to definitely want Professor Madras to answer the question. But it is quite striking that our federal policy only allows medical research on cannabis in one facility, one institution in the whole United States, at the University of Mississippi. That's bizarre. But now go and answer, if you would answer the mayor's question.
With
please.
all due respect, that is the source, but that is not the only facility. There are 300 clinical trials with cannabis. I prefer to call it marijuana because cannabis is the same as calling opium Papaverum omniforum. It's a Latin terminology which tries to sanitize the fact that in this country it's marijuana.
Weed.
But there are many strains. There are many. There are many strains. There are many possible.
There are many strains,
which have very different properties medically.
But basically, the two big ones are THC and CBD.
Right.
And THC now is up to 90% in some dabs, and CBD has been essentially bred out of the plant.
So what
Paul
is
Larkin
the
and
relationship?
Paul Larkin and I, who's a lawyer, have just published, it's going to be in the Georgetown Law Review, a complete summary of the data and the evidence for and against using cannabis. And so there is a level of familiarity with the question and the answer. At this point, there are two conclusions. Number one, the data does not show that cannabis is a substitute, because if you actually do longitudinal studies on an individual basis, you find that people are suffering as much pain if they're taking marijuana, and their opioid use is not decreasing in most cases. It's in fact, they're getting more and more in trouble in terms of developing opioid use disorder, and they're misusing opioids. That's basically the latest data. One publication just came out last night on it. Number two, every single disease that is treated in this country, like diabetes, like infections, like cancer, is evidence-based and undergoes randomized controlled clinical trials. And to say that this is by legislative support or by fiat from a governor's office, that this is how you can treat opioid use disorder without the clinical trials, without longitudinal studies, to me is purely disrespectful of patients.
Yeah. Yeah. Agree.
Well said.
And it's a totally different issue what the trials have shown about how it can decrease pain in other
There's
areas.
only no more, to the best of my knowledge, 5 randomized controlled trials in neuropathic pain, which is a very special type of pain. And of those trials, none of them lasted more than 2 weeks. They were all experienced marijuana users. They were all on opioids. And that's exactly the problem that got us into the opioid crisis, because people did not do longitudinal studies on opioids. They just did it at the time that this crisis began, there were no studies beyond 3 months.
Yeah. So you take real exception to the National Academy's
The National Academy report on chronic pain was in deep, profound error.
There you have it.
Okay.
The news at
And
11.
even though I am now on the Opiate Collaborative, I'm willing to come out and say what is the truth.
Okay, next question. The Emily Arfman, who is an incoming Wharton student. Emily, congratulations. Yeah. How is government thinking about its role in improving patient access to medication-assisted treatment?
Oh.
So how is government thinking about its role in improving patient access to medication-assisted treatment?
That's above my pay grade.
Well, I'm saying,
I can answer for Mayor Kenny,
Yes.
because in the city of Philadelphia, we have treatment capacity for MAT that is not being used. Right. So they have lowered the barrier. There is lots of opportunity. We are working really hard to get patients into treatment, but we have tremendous capacity. That's probably unlike most other cities, but we have 3 patients dying a day in Philadelphia. We are at a huge crisis, and that's why we need safe injection facilities, safe house, other places where we can get people in. If they're not coming into our treatment centers and they're not coming into my emergency department, we need to reach them some other way, and we're doing a lot, and Mayor Kenny should be applauded because he's done a really amazing job.
Professor Madras, what's your view on the, getting people who need to be in treatment facilities in?
Yeah, there are a couple of issues. The vast majority of people with an opioid use disorder do not come to treatment. And when it's excavated into, granular level, you find that many of these folks do not want treatment, do not seek it. Another part says they don't want to get into treatment because of stigma. They're afraid their family will find out, they're afraid their employers will find out. Recruiting people who are not in treatment, to me, is one of the most important issues, and having them be offered medications is a critical feature of this. How do we do it? The federal government is critical through CMS, because CMS has tremendous control. Number 2, the federal government, every year, the Office of Personnel and Management issues a call letter to all the insurance companies that insure federal employees. That call letter has tremendous impact on all the insurers in the country because it sort of guides the entire country's reimbursement model on what the federal government considers critical. And that call letter should include that you must make medications available. It is harder to get approval for medications to treat opioid addiction than it is to get approval to give someone a Percocet prescription. And that's wrong.
That is deeply wrong.
We put that into the commission report.
Yeah, and this actually, so insurance companies could change that, right?
They could put the squeeze in both directions. They could squeeze the physicians in terms of prescribing opioids, and they could squeeze physicians, not squeeze them, but empower them to prescribe medications which reduce death rates, HIV, hepatitis C, and so on.
Hear, hear.
And maintain people in treatment.
One of the crazy quirks of our reimbursement system is that doctors, we've been banging on doctors maybe too much, I'm not an anti-doctor guy, but in this particular case, when they prescribe, they make more money, they get a 6% commission more or less for prescribing, and the natural inclination is to prescribe non-generic drugs. And so if you're looking at access to medications, a lot of times people stop taking their medication because they don't have insurance, and it's quite expensive. So expanding generics across the board in this field and in other areas as well, I think would be part of this. And I'd go back to another point, which is that treatment is short term. I mean, in the most the most expensive places, I'm sure it goes on for more than 30 days, but most people have insurance for 30 days and then they're out. So reforming the treatment system, looking at best practices, benchmarking it properly, rewarding the successful programs, stopping the ones that don't work, all those things have to happen. But I think the last part of this is that we need to create, the stigma issue is a serious one, and people are going to be, their lifelong journey is going to require a commitment to recovery. Whether it's alcohol abuse or drug abuse, these addictions don't go away. You can deal with them, and if you have the courage to do it and the family support and the support in the community, it's a lot easier to do. But that's something that's foreign to most places in this country. We don't have that kind of environment where there's that support.
So you said earlier at our lightning round that if you could change one thing, it would be the culture. And can you just elaborate a little on what part, a part of our culture that you think is we could all play a role in changing?
The two parts, I would say. One is if it's a third of the prescriptions, that's bad. If it's 85%, which I think it is, in the world with 6% of the population, that's absurd. That's a cultural problem. I mean, we're not, that's so unique to us that we have to deal with the fact that every problem in life should
have a drug as its answer.
Another pill.
Yeah.
And then the second is the stigma that really isolates people rather than brings them into a more nurturing environment where the families and communities and churches and synagogues are there to help people deal with with this illness over the long haul. I think is what's we've torn apart a lot of the things, the safety net, the real safety net of America, and rebuilding that to deal with these kind of issues would be.
And if you'll excuse, to that we should say amen, because it really does take community. It takes institutions, churches and synagogues, mosques, community centers.
Yeah.
This is not something that anyone can struggle with alone, right? You need really, so that's a very important antidote to, the individualist impetus of our society where, and that feeds into all you have to do is take a drug, right? But you really need a community of support.
Yeah, and people have to be committed to do this. I mean, the drug court issue works not because it's necessarily diverting someone from jail. It works because the threat of jail is still there. so you complete your sentence and you,
Yeah.
you have your adjudication withheld. That is a powerful tool to keep people on the straight and narrow. And there's, you know, along the way there may be people make mistakes, but they stick with it far more than if you just put them in jail, they get out and immediately they go back to their bad behavior.
I would like to paraphrase Governor Bush and also Vice President Biden, because I learned in government that you have to talk in sound bites. We have to denormalize chemical coping and chemical reward, because that is the basis of our drug problem in this country.
That's a
Doctor,
soundbite.
let me ask you a question. You know, for a while,
Sophisticated sound.
10, 12 years ago, there were a lot of people with your collective expertise who were talking about the need to go back to studying the brain to find antigens and antagonists that would prevent the drug from having the effect on the brain that it had. I met with every major drug company, and we talked about an Orphan Drug Act, which we would provide them for significant rewards if they were to find this. None of them are interested in it. None of them are interested in it because, number one, they don't want to be known as the drug company in terms of illegal drugs. And secondly, there is little reward, notwithstanding all these people that are dying and all the people are addicted to opioids. There's still not enough money to make from that particular population, which can't buy the drug anyway if they found it. Is there any more talk about this anymore?
Well, there are a lot more pharmaceutical companies entering the fray now because they're very interested in isolated cannabinoids. They're interested in what are called biased agonists, which are opioids that are going to develop different signaling pathways than the conventional ones, which will not lead to addiction or overdose, but will lead to pain reduction. And there are companies that are very interested in developing pain medications that are non-addictive. There are also drug companies that are interested in developing medications to alleviate. It's become now more normalized, more centralized than it used to be in the past. So
I think it is, but there's a small percentage of money.
Very small.
Very small.
One of the reasons that it's very small, besides, and I won't enumerate all of them, but one of the main reasons is the difficulty of conducting clinical trials with people that have substance use disorders because of the high dropout. Once you have a high dropout rate, you have to explain that to the FDA. Once you have a high failure rate, then you may have invested $2 billion. And because of the high failure rate, the 25% or the 10% that are successful may not be enough to convince the regulators. So because the population is much more difficult than it is for chemotherapy, there is a lot more problems associated with developing drugs for substance use disorder.
So I just want to say on behalf of everybody here how much we've learned that really could, and I hope will, make a difference to every family in this country, because I just think we need to understand and underscore what this panel has said, that this is an issue that knows no economic or racial or religious distinctions. It really affects everybody here. And please join me in thanking Professor Madras, Governor Bush, Mayor Kenney, Dr. Perrone, and Vice President Biden.